Hello, you're welcome today to the continuation of our discussion on the course Primary Health Care. And we are taking the discussion as a sub-discussion under this main course, Primary Health Care. We are looking at the training and support of the primary health care workers. Remember, in our part 1, we looked at the introduction, and in the part 2, we looked at the context in terms of the history, where we are in Nigeria, and also we looked at history along the global context. And we also took time out to look at the different, aspects of it. And I know that you can access those videos and learn a lot from them. Today we'll be going to the part 3. My name is Dr. Isagboyi Henry, and I want to welcome you once more and thank you for taking out time to listen to past videos. As I said, we'll be continuing with the part 3. And in the part 3, we'll be looking at the training of the primary health care workers. However, before we look at that, there is a key feature that I love to talk about. These key features, I like to reiterate it, even if I talked about it in the last video, because it will play a stronger role or impact in the discussion that we'll be having in the part 3. So let's talk about one of Nigeria's most important community health initiatives, which is the community health influencers, promoters, and services. I told you it's known as the CHIPS program. Now, this program, represents Nigeria's modern approach to strengthening the primary health care at the grassroots level. And it was designed to harmonize multiple community-based health efforts under one coordinated system. I told you that it was a lot of programs going on at the time, and they were not properly supervised, and many of them were working independently in order to bring them under one roof so that the government could use them properly and utilize the efforts to avoid redundancy and then also overlapping of duties and so on. And so it was necessary that this approach, came up. So it was designed to harmonize all the multiple community-based health efforts and bring them under one coordinated system. Let's look at the integration aspect. The CHIPS program brings together the different community health volunteer programs that used to operate independently, like the village health workers, community resource persons, and other donor-funded initiatives. It had to bring all of them into one unified framework. What this means is that rather than having scattered efforts, the CHIPS ensures that standardized training, supervision, and monitoring across the country is ensured, guaranteed, and properly, structured. For example, a CHIPS agent in Kano State and one in Cross River State, are trained using the same curriculum, monitored with the same tools, and supervised through, their nearest functional PHC facility. That's the way it should be, regardless of the region or the distance. But that's absolute control in terms of monitoring, in terms of the curriculum for training, in terms of the tool, in terms of supervision will be intact. Now, this integration promotes efficiency, and it's so fantastic such that it eliminates duplication. And so there's no overlapping of roles. And then it ensures that there is data consistency for national health planning. We also have a specific aspect of it that makes it interesting. And that's the aspect of volunteerism. One of the unique strengths of the CHIPS program is that it operates primarily on a volunteer basis. CHIPS agents are selected from within their communities, often respected, trusted individuals such as mothers, youth leaders, or traditional birth attendants who are motivated by community service rather than salary. These persons may not be paid, or they may be given remuneration, perhaps not that much, but they are motivated by community service. And so you see them volunteer. You can't force them. You can't drag them into the system. They come by basis of their passion to serve. This volunteer model promotes community ownership, and then it brings about sustainability, which are the key principles in public health. So when people feel a sense of belonging and responsibility, the program becomes part of the community's identity rather than an external intervention. They see it as their own. For instance, in Sokoto State, community leaders help nominate women to serve as chief's agents, ensuring that the program is rooted in local trust and participation. Another good aspect of this program is the supervision. Supervision. That's another key features. Supervision. Now let's look at how the system stays functional. Each chief's agent is linked to a primary health care facility in their ward. Now this facility serves as their supervision and reporting hub, where trained health workers provide oversight, they collect data, and they replenish supplies. So look at it this way. Think of the PHC as the command center. It ensures accountability, it ensures mentorship and alignment with national health goals. Through this model, information from households flows upward to the PHC and then to higher administrative levels, forming a complete feedback loop for data-driven decision making. Remember this statement. Think of the PHC as the command center. In that place, you find all the agents reporting because they are attached to the PHC facility. That way, accountability is ensured, mentorship is ensured, and they ensure that they are aligned with the national health goals, not just doing what they like or what they feel is necessary. And so with that model, information will move from the households. From that household, the information will flow upwards to the PHC, and from the PHC, data is collected, harmonized, and then it flows to the higher administrative level. And that's a complete feedback. And when you have that kind of feedback, there will be proper data-driven decision making. Let's see the impact of this CHIEFS program. Let's see the results so far. So far, the results have been impressive. CHIEFS agents are bringing essential health services right to the doorsteps of rural households, from health education and nutrition counseling to malaria prevention, immunization, mobilization, and referrals for maternal care. According to the National Primary Healthcare Development Agency, communities have enjoyed this privilege. And all those communities that have been served by CHIEFS agents have recorded increased antenatal care attendance and improved immunization coverage. In fact, in one local government area in Niger State, for example, CHIEFS agents were instrumental in tracking missed immunizations during outreach, helping raise child vaccination rates by over 30% in less than a year. For those who probably one way or the other, because of the nature of the demography, they missed out of it, they were able to track them. And those children were saved by bringing them out so that they can be vaccinated. And that improved the rate in less than a year. Another advantage is another impact that we've seen in the national and global relevance. The national and global relevance. Beyond immediate community impact, you will see that the CHIEFS contributes to Nigeria's pursuit of the universal health coverage and sustainable development goals, especially the SDG 3, which focuses on ensuring healthy lives and promoting well-being for all. It also mirrors the success of India's ASHA program. I told you, very successful, where female health volunteers became instrumental in improving maternal and child health outcomes. You see, Nigeria's adaptation of this model has shown a commitment to a kind of context-specific solution, a commitment that can solve problem in the locality. Very important. And it has shown that people can learn from it, from global best practices, and yet tailor it, to their local realities. So, in essence, the CHIEFS program represents a powerful example of how community, engagement, supervision, and structured volunteerism can reshape the landscape of public health. Remember the word engagement, supervision, and structured volunteerism. Now we will move into exploring how training models for PHC workers, how are they developed? How do they work? Including the chief's agents, how are they trained? We also want to see how the model is structured in order to ensure that it is competent, in order to ensure that the chief's agents are motivated, and that on the long run there will be a long-term impact. So we move to the main discussion for the day. So let's see the components of effective training for PHC workers. Now let's dive deeper into what makes training for primary healthcare workers truly effective and impactful. Training is not just about transferring knowledge. I believe we all agree with that. It's about building their confidence, their practical skills, and the trust of the communities that they serve. And you see that this holistic approach ensures they can deliver care that is relevant, respectful, and sustainable. Now, we will look at the basic health knowledge as a foundation for any PHC worker. You can't just be a PHC worker without having, gone through any training. There are some basic knowledge that any PHC worker, when we mean basic, that's the least borderline. You must acquire that knowledge. Now, the foundation of any PHC worker's training starts with essential health knowledge, and this includes key areas such as nutrition, sanitation, and disease prevention. Nutrition, sanitation, and disease prevention. Now let's look at nutrition. The PHC workers learn why balanced diets matter, how protein, vitamins, and minerals work together to keep people healthy. For example, they teach mothers how to provide age-appropriate complementary foods, which helps prevent childhood malnutrition. And remember, it's a leading cause of illness worldwide. And that's an essential role. And that's why they have to have a good knowledge about nutrition. Again, sanitation. They need to understand what sanitation really means. And it means promoting everyday practices like hand washing with soap, safe waste disposal, and clean water use. So when PHC workers educate communities about these basics, they help reduce infections like diarrhea, which accounts for a significant proportion of child mortality, especially in low-resource settings. And this is very important. On the area of disease prevention, workers are trained, these PHC workers are trained to identify common risk factors such as stagnant water, breeding mosquitoes, or unsafe food preparation, and to encourage preventive behaviors like using bed nets or vaccines. And this empowers them to advocate for healthy lifestyles in ways that resonate personally with community members. And so by mastering this basic health knowledge, PHC workers can now break down complex medical concepts into simple, practical advice that people understand and people can trust. So this builds a strong foundation for all other health interventions. So number one of the components of effective training of the PHC workers is the basic health knowledge. Very, very important. The second one is the skill development. The second aspect of the component of effective training, we say skill development. Here, the basics in clinics are taught. They are also taught about first aid and how to carry out proper counseling. The third aspect that they are taught is the communication skills. they are properly trained. But remember, they have an advantage here because they return to their locality where they actually come from. Remember, they indicated their interest as volunteers from that community. And so they are returned to that community. And so they understand the culture, they understand the language, and effectively, in addition to the training they are given, they are able to communicate. So they educate diverse audiences, those who are originally from that community and those who have arrived that community, either for business, for farming, or whatever endeavor. Number 4, we see data collection. They are trained on how to collect data using tools for health reporting and also monitoring. They are given some little devices, some little statistical tools where they can put in simple data, and when it gets to the PhD level, it is now collated by the expert there and then sent to the national or the state level. What training modalities do they use? They use the classroom training. And you know that's the foundational health education platform. Trainings take place under the roof in what is known as a classroom. You also have on-the-job training. This is where you pair persons together with mentors. And these PhD workers work alongside those who are already experienced, and then they get the needed practical exposure. Another training modality is using the mHealth tools. Here you have videos on lectures on certain aspects already put with example slides, and then they have time to look at them from time to time on the field when they are less busy, and then they read or they listen just like you're listening to me right now, and then they are able to carry out what we call continuous updates in terms of assessment, in terms of building their capacity, and so on. So these are the very components of effective training: basic health knowledge, skill development, communication skills, and data collection. I've seen the training modalities, which include classroom training, on-the-job training, and the mHealth mobile health tools. We move to the next slide, and we are continuing with case studies. Let's explore real-life examples from different countries on how they, train primary healthcare workers. These case studies offer valuable lessons that Nigeria and other nations can adopt to strengthen their own health systems. For example, we look at Nepal, the female community health worker volunteers. Nepal's FCHV program is a standout success in Asia. Now, these volunteers, all women chosen from local communities, undergo specific training to deliver essential health messages and also to support safe motherhood. And what was the impact? Because they were consistently educating the mothers on safe childbirth and newborn care, Nepal has seen a remarkable reduction in neonatal mortality rates. You can see that in Glenton et al. 2013. For example, they teach about recognizing danger signs during pregnancy and also promoting breastfeeding, which has saved countless newborn lives. Now, what are the lessons learned? Number 1, we saw that it empowered the local women through targeted training boost, where you have community health training, community health discussion. They brought them together, and talking to them helped them to be able to learn a lot about health outcomes, especially in the area of maternal and child health. So when women in the community lead health efforts, their acceptance and effectiveness indeed increases. Let's look at another example, another example in Uganda, known as the village health teams. The village health teams. Uganda's approach combines classroom learning with hands-on field experience, and that's a blended training model. For example, the village health teams receive instruction on diagnosing and managing malaria, performing rapid diagnostic tests, and distributing bed nets. So they split their time between formal classes and supervised community work. The theory and the practical together. This method enhances both skills and confidence in managing malaria locally. You can see that in Kawuki et al. 2020. We also see that there is lesson to be learned, and which is that training must be practical. It must be rooted in the community and directly address pressing local health issues for maximum impact. You will notice that we have talked about the village health teams as an example, and we have seen one thing very spectacular there. While they are having their formal classes, they also go for supervised community work. And here we see that training must be practical and rooted in the community where the practical takes place. And indeed, it was directly addressing pressing local health issues, and it was giving out maximum impact. Now let's see the training pathway for PHC workers. The training pathway for PHC workers, regardless of the country, effective training programs for village or community health workers usually follow a similar pathway. Number 1, selection and recruitment. Number 2, basic training. And number 3, specialized training. Number 1, the first, that's selection and recruitment. The first step is choosing suitable candidates, trusted members of the community who demonstrate, number 1, genuine commitment to service. They demonstrate basic literacy skills, and they also demonstrate strong interpersonal communication abilities. So when PHC workers come from the community itself, people are more likely to trust them and follow their health advice. Now, this social trust is very important. It's key to successful health interventions, because when people don't trust the process, they don't trust the health workers, they won't cooperate with them. So let's see number 2, the training pathway, which is basic training. Selected trainees participate in a foundational course covering principles of primary health care, also covering common diseases and their prevention, and also effective health education techniques. In this phase, these workers are equipped with the essential knowledge that are needed for community engagement and health promotion. Let's see the third training pathway. The third one is specialized training. Next, these trainees, they receive what we call focused instruction. At this point, maybe an exam would have taken place. Those who passed the exam move to this stage, and they are given specialized training where focused instruction in targeted specific areas such as maternal and child health, nutrition, immunization programs, and infectious disease control is given to this set of persons, because they have the cerebral capacity to manage that information and to manage that capacity. For example, a primary health care worker might be trained in malaria management techniques, how to monitor child growth, or how to support antenatal care visits. These skills enable them to deliver specific high-impact interventions. Number 4, as part of the pathway, is also practical experience. Practical experience. Finally, at this aspect, these trainees perform supervised field work. That's where the peering, the mentoring now takes place. They are paired with somebody that is advanced in this field, and they work with that person and learn the practical experience on the field. There, they translate classroom knowledge into real-world action, conducting home visits, leading health education sessions, and administering basic treatments under oversight, under supervision. Now, this hands-on experience will build their confidence and competence, and it will prepare the PHC workers to serve their communities effectively. So, in summary, as we end this slide, successful PHC training programs like those in Nepal and Uganda have demonstrated that combining community trust, practical training, and local relevance will strengthen any health system. By adapting these lessons, Nigeria and other countries can enhance their primary care workforce and improve population health outcomes. This is very, very important. We'll move now to slide 27. Slide 27. And there we'll be still talking about the training. We'll be looking at certification and continuous education. Remember that we have looked at how primary healthcare workers are trained. So now let's focus on what happens after training finishes, because learning does not just stop at graduation. Of course, you all know that. To build a competent and confident workforce, there are two critical steps that follow. Number one, certification. And number two, continuous education. You can see on these slides, you have refresher training for community health workers in northern Mozambique. They are called back from the field and they are being given retraining, improving on what they have learned, refreshing their knowledge so that they can go back to the field more robust with knowledge. And so, certification and continuous education are critical steps that follow after the training. So let's begin with certification. It simply means validating competence. Validating competence. That is, somebody is competent and you are providing an evidence that this person is competent and he can show it anywhere. Once the PhD workers complete their training, they must undergo competency assessments. Now, this usually include written exams, practical demonstrations, and supervised field evaluations. What's the purpose of this certification? The certification ensures that every PhD worker can confidently perform essential tasks, whether giving immunizations, whether providing first aid, or delivering community health education. For example, in Nigeria, the Community Health Practitioners Registration Board of Nigeria certifies community health extension workers, that's the CHUs and the junior CHUs, before they begin practice. That's where they get their permits from. This official recognition confirms that they meet the national standards to serve safely and effectively anywhere they are posted to. And why does it matter? It matters because certification adds professional credibility and public trust, thus elevating PhD workers as recognized frontline health professionals that are capable of delivering quality care. On the aspect of continuous education, after you've been certified, you don't just go indefinitely without renewing the knowledge, because a lot would have changed. And that's why we say continuous education is a lifelong learning process. You have to keep coming back to relearn, because there will be updates, drugs are changing, treatment model is changing, and other informations are being updated from time to time. So health knowledge is never static. New diseases will emerge, technologies will evolve, and community health needs will change. So continuous education keeps the PhD workers updated, it sharpens their skills, and enables them to respond promptly. Let's see some of the examples of continuous education. Some examples of continuous education. They include refresher workshops on topics like immunization schedules or outbreak responses. What happened? How it happened? What effort did they take? How were they able to cope it? And what were the dangers? And how were they able to overcome that danger in that country? This will be taught to the PhD workers as a refresh course. Mobile learning platforms that send short, accessible training modules via phone, allowing learning anywhere, anytime. So that's another example. They have the tool with them, they're able to go through it, and they're able to learn. We also see supervision-based learning where experienced mentors guide the PhD workers during routine field visits. They also learn from this. They also have the annual certification renewal requiring documented evidence of ongoing training and professional development. That also helps so that continuous education will remain in place, because you will have to do what we call certain courses in form of units. And the more units you gather, you can now renew your license. So, as a case, countries such as Ethiopia and Kenya have successfully integrated e-learning and periodic refresher sessions for health extension workers. And this has helped them to stay effective, motivated, and connected, even in remote or resource-limited areas. And such is also going on in Nigeria. However, there are challenges of the internet and so on, but it is important that the vision remains, keeps running. And as the internet gets to those parts, the health workers over there are able to access this information and keep learning. Therefore, in summary, certification validates the professional identity of PHC workers, and it signals that they have the necessary skills and knowledge. Continuous education, on the other hand, ensures that they remain relevant, capable, and ready to face evolving challenges. By this, we see that together these steps guarantee the PHC workers are very, very important, and that they don't just remain the way they were after the training, but they stay strong, because actually they started strong. And in order to stay strong, having started strong, they have to keep overhauling the system themselves, their knowledge, so that they can consistently keep serving their communities stronger with confidence and competence. So you can see here another set of village health workers, which is also known as the primary health care workers, having training. And you can see this is a classroom training where you can see, posters all over the wall, and they are describing it to them, maybe as a case studies, one by one. And you can see essentially some male there and some women as well. At this point, we want to see the support mechanisms for PHC workers. But that will be another discussion for another day. And so I want to conclude at this point, and I believe that you have taken time to see how the PHC workers are trained. And you have seen the details, and you have seen the importance and the impact. If you enjoyed this video, please like this video and also subscribe to my YouTube channel. And as much as possible, you are free to ask questions on the comment section, and I will attend to them. Please remember to take notes, and remember to also do some extra reading based on the information that you have received. And also, you are free to, like I said, ask questions, and I will attend to them. Till I see you again in the next lecture video, thank you and take care. Bye.